Hi, I am Arathy Kartha, a postdoctoral research fellow in the Ultra Low Vision Lab at Wilmer Eye Institute at Johns Hopkins. My research is focused on functional vision and rehabilitation in people with ultra low vision or profound visual impairment. There are currently 1 million Americans with profound vision loss. The conditions causing visual impairment and functional blindness vary between individuals, but the most common conditions are inherited retinal degenerations, glaucoma, and diabetic retinopathy. Loss of vision has a huge impact on the emotional and mental well-being of an individual, with higher rates of depression reported in people with visual impairment compared to those with normal vision. There is also a higher rate of unemployment among people with visual impairment, with only half of the visually impaired population even entering the labor force. This results in loss of emotional and economic independence, causing a social and economic burden to the individual and society. The total annual economic impact of visual impairment and blindness in America is close to $51.4 billion US. When we talk about visual impairment, we may be referring to reduced visual acuity or field of vision. But visual acuity is really the most important measure used to quantify vision. It is the ability of the eye to resolve small details, such as the ability to differentiate letters, shapes, or symbols. Visual acuity is measured not only during routine eye examinations, but it is also the most used measure for studying the effectiveness of various treatments, such as in clinical trials. For example, clinical trials often report an increase or decrease in the number of letters a person can read to report success or failure of a trial. Anyone who has taken an eye test at the eye doctor's or at the DMV knows about eye charts. It has letters and numbers of different sizes. Some charts have been designed with shapes or symbols for testing in children. But what happens when we are not able to measure vision using the traditional eye chart? What if a person is not able to read any letters on the eye chart, even if it is brought closer to a distance of half a meter? This category of visual impairment is identified by the term ultra-low vision and happens in advanced stages of eye diseases when people lose their firm vision and are unable to resolve small details such as letters or symbols or even recognize faces. This does not mean they are totally blind. They can differentiate between light and dark, are able to tell if it is sunny outside at noon, or even whether the room lights are on or off. This means that they do have some functional vision that they could use to perform some activities of daily life. For example, spotting a bright window in a room, finding open doors in hallways, or even the crosswalk lines. But we are not able to measure this level of vision using the currently available tools. Why is it important to develop tools for measuring functional vision in people with profound visual impairment? Firstly, it is important to know the visual potential of a person so that they could be referred for appropriate form of vision rehabilitation to improve independence and quality of life. Second, there are a growing number of sight restoration therapies that recruit participants with ultra-low vision or with advanced stages of eye diseases. So it is important to have tools that assess vision before and after treatments to measure outcomes. The Ultra Low Vision Lab at the Wilmer Eye Institute, led by my mentor, Dr. Jilon Danieli, has been developing a profound low vision rehabilitation curriculum known as PLOVER using questionnaires and performance tests. Currently, we are developing tests for functional vision in 3 domains. First is visual information gathering, such as whether a person is able to tell if somebody standing in front of them is wearing a tie or not, or the detection of motion of cars. Second is eye-hand coordination, where we assess their ability to point, reach, and grasp for objects which are moving or stationary. In each of these situations, we are able to vary the contrast or the speed of motion so that we can make the test difficult or less difficult to manipulate the scenario. Third is visual wayfinding, where we assess their ability to cross a street safely. So using real-world scenarios recreated in virtual reality, we are able to assess or design tests that precisely measure visual ability in people with ultra-low vision. So the participants are asked to perform a range of activities, and scoring them on their performance reflects their ability in the real world. I am validating these tests now so that they could be used for clinical trials during baseline evaluations and as outcome measures. The advantages of using virtual reality is that it could be done anywhere, including patients' homes, which is useful for people who don't travel, such as the ultra-low vision population. Another advantage is that it can be controlled and administered remotely that allows for social distancing during testing.